infection with MDR bugs, patient on hemodialysis, patients with low functional status. How would you understand the severity? Patient will present in septic shock, may have a history of prolonged ventilation or long ICU stay, immunocompromised hosts, neutropenics, transplant patients, hematological malignancies, patients who've undergone recent invasive procedures. So with this clinical flow, it tells you upfront the possibility of that you might be dealing with an MDR. Now we have a very large national antimicrobial resistance data, but it is your ICU antibiogram that should help you derive the empirical therapy. Because in hospital acquired infections, as well as ventilator associated pneumonias, Acinetobacter and Klebsiella often predominate. And carbapenem resistance, we all know, we see quite commonly in the Indian ICUs. So your empiric antibiotic therapy would largely depend on your ICU antibiogram, and you must always keep that and consider that before actually choosing the empirical therapy for your patient. So let us begin with understanding the basics of diagnostic and therapeutic stewardship. So sending the right sample, interpreting the right result, and then de-escalating or narrowing down the therapy is what basically includes in the stewardship. So for diagnostic stewardship, it is important to send the right sample at the right time. However, do not delay initiating your therapy just because you want to send the sample, which again is a very important aspect. So when you have suspecting bloodstream infections, you must send uh, 2 sets of blood culture. How's your pain? Which includes in one aerobic, one anaerobic, minimum 10 ml of sample from at least 2 different peripheral sites. If you have a patient of VAP or HAP, then endotracheal aspirates. If you're planning a bronchoalveolar lavage, then you send a lavage or quantitative or semi-quantitative cultures. In patients with UTI, you must send fresh midstream. But remember, if your patient was already catheterized, do not send the sample from the old catheter because you then may start treating patient with asymptomatic bacteriuria. So change the catheter. For abdomen, if it's a sterile intraoperative aspirate, that is one of the best samples. If you put in a train, send the samples from the fresh train there and then, because again, old in situ trains have the risk of colonization. For CNS infections, if you're sending CSF samples, cell counts, your biochemistry, gene expert for mycobacterial tuberculosis, biofire encephalitis panels, they all are a part of investigating depending upon the syndrome that you're dealing with for CNS infections. So you send the sample and you get the report. How would you actually interpret it or understand it? So first and the foremost, look at the specimen at the site from where you send the sample, and then the organism. A sterile site isolate would carry more weight than sending a colonized drain or a sputum sample. Then drug clues: ceftriaxone, cefoxitin, cefepime MICs. Look at the carbapenem MIC and colistin MIC. Do not equate every in vitro S, every report that says S, that is sensitive, means that this drug is going to be successful if you choose it. And because I said, you have to remember the PKPD. Does that drug actually penetrate that site of infection? Will it be effective for that bug at that site of infection? Is what you should always keep in mind. A word about biofire and multiplex PCR. So, these are very widely available these days and are being used quite often, especially in tertiary care centers. So, biofire and multiplex PCR, they help you in early organism detection in severe pneumonia and bloodstream infections. Remember, they are, they support early escalation and de-escalation, but they do not replace your culture and AST testing. So you have to send the sample for the culture and AST, but yes, early targeted therapy can be initiated, but do not treat it as a test of cure. Biomarkers, again very widely used and often misinterpreted. So they support de-escalation. They are not your decision makers. A procalcitonin in a patient who is in septic shock, hemodynamically unstable, rapidly deteriorating with a low procalcitonin does not determine that you do not give appropriate therapy or start de-escalating. It is important to interpret it properly, look at the trend values to actually assess clinical response. So it is better used when it's for de-escalation, when the patient is improving. So your questions that you should be actually asking is there a compatible infection syndrome? Is the patient in shock or rapidly deteriorating? Do cultures or imaging support infection? Can antibiotics be stopped safely today? That's what you should be keeping in mind and thinking when you're looking at your procalcitonin values.
How's your food out?
So since we are talking about resistance, very quickly and basic of the resistance mechanisms. So there are four roots, basic roots of resistance. One is the enzyme destruction, which is that beta-lactamases hydrolyze penicillins, cyclosporins, and carbapenems. There can be an access problem, that is loss of foreign channels which prevent entry, or efflux pumps which remove the drug altogether. Target site can be changed, that is penicillin binding protein or liposomal changes, and they reduce the drug binding. And then drug modification with aminoglycoside modifying enzymes which inactivate the drug altogether. So resistance failure comes from all of these together. It is not always just the drug failure.
Okay, I'll give you some medicine, it will come
Then
down. And for your back
resistance
pain, I'll give
genes.
you one more injection.
So the mechanism, the rapid panels, they help us detect a lot of genes these days, and they tell us about the presence of carbapenemases and beta-lactamases. So if you see a CTXN or KPC or OXA48 or 23, they indicate specific resistance, and there is specific therapy which is available for each of these. So we will understand this as we go ahead.
And your partner contact, you have to be stopped.
Like I said, your site of infection and your drug of choice matter. So when you're selecting a drug, you need to know whether it actually is a good fit or not. For example, if you select TG cycline for a bloodstream infection or UTI, it will not be effective. So it is a poor fit because it does not penetrate. It has low serum and urine levels. Similarly, polymyxin B for UTI, there is no renal clearance, poor urinary concentration. IV colistin and polymyxin for pneumonia. Nitrofurantoin should not be used for pyelonephritis and bloodstream infections. Fosfomycin oral should again not be given for bloodstream infections or systemic infections. And eravacycline for UTI. So these are not good drugs because they do not penetrate these sites. So how would you choose an antibiotic? First and the foremost is to look at your patient. Is your patient stable or is he in shock? Does he have an associated renal or liver dysfunction? Is he obese? Because that would change your dosing. Is the patient on CRRT or ECMO? Is the patient was the patient on burns? So that would, all these would change your choice of drug as well as the dosing. Then the bug. What is the bug that you're treating and the likely syndrome that you're dealing with? Does the bug have any MDR risk factors associated? Then, like I just told you about the site of penetration of the drug, remember, do not modify your loading doses just because the patient has a renal dysfunction. It is important that the loading dose is given fully for most of the drugs, and you accordingly choose your infusion strategy. Remember, if you have started a drug, you need to monitor for toxicity. That is something that should always be checked. After choosing the right drug, the right site, depending upon the bug and the syndrome, the source control. If you don't do this, your patient is not going to get better just based on your culture sensitivity report and your appropriate antibiotic of choice. So you need to drain, remove, debride, and image if the patient has persistent symptoms, the cultures are not clearing, or the patient is worsening despite your adequate active therapy. Now we've understood the stewardship, we've understood the drug and the bugs and the combinations. So there is syndrome-based approach for gram-negative bacteria. So you choose the treatment by infection site first, and then look at the resistance mechanism, of course. So beginning with UTI with gram-negative bacterial infections, what is a colonizer and what is a true infection? So when do you always treat symptomatic cystitis with a compatible urine culture? Always treat pyelonephritis, urosepsis, pregnancy with bacteriuria, and before invasive urological procedures. You do not treat an asymptomatic bacteria, uh, growth from an old Foley sample with patients having no symptoms, a mixed flora which only tells you that it is these are all colonizers, and a patient without a syndrome growing multiple MDR gram negatives. So you don't treat these. Then for uncomplicated cystitis ESBL, the preferred drug of choices are nitrofurantoin, trimethoprim, sulfamethoxazole if you have a confirmed susceptible. Alternatives include fluoroquinolones, aminoglycosides, very selected cystitis, especially when your renal risk is acceptable. Fosfomycin, used very carefully for E. coli only, and avoid coamoxiclav as well as doxycycline because they have lower efficacy and poor urinary exposure. For complicated UTI and pyelonephritis ESBL, if they are susceptible, trimethoprim, sulfamethoxazole, and fluoroquinolone, Cipro, and Levo can be used because they have a high oral bioavailability and support step down. If no oral option is available and you're thinking of an OPAT strategy, then ertapenem is a good choice. Patients who are critically ill, hypoalbuminemia, your drug of choice becomes carbapenem, that is meropenem or imipenem. Avoid, again remember, nitrofurantoin, oral fosfomycin. Do not use them, and a piptazo sensitive on your culture sensitivity report in severe infection should not be used. Then basic principles of gram-negative and bloodstream infections. The golden rule is that start active antibiotic therapy early. Send cultures as soon as possible. Do not delay therapy. Source control is equally important, and you do not have to keep repeating blood cultures if the patient is improving, unlike in cases of staph aureus. And if the patient is persistently symptomatic, the source is not controlled, or you're dealing with a deep-seated infection. Most of the uncomplicated gram-negative bloodstream infections, 7 days of therapy is enough when the patient is stable and the source is controlled. And do not use TG cycling and avoid polymyxins when safer options exist. Then the next gram-negative infections that we're going to look at is the lung, that is your HAP and WAP. So again, empiric approach, like I said, antibiogram is not just for HAP WAP, it is for any infection in your ICU. You must not forget your local antibiogram. You cover for Pseudomonas and Acinetobacter when the risk is high, and 2 anti-Pseudomonal classes only when there is shock or you're dealing with a patient with high resistance settings. Remember that endotracheal aspirates can grow colonizers, and a polymicrobial low copy biofire may be also showing you colonizers. If your biofire is negative, but the patient presentation and everything suggests more of pneumonia, you should also think of Xenotrophomonas, Burkholderia, fungus like Aspergillus, and non-infective mimics.
This is common, so many people they will get.
Then when you look at a biofire sample, ball sample, what tells you that this is a true infection or it's a colonizer? So a true infection patient would have fever, purulent secretions, worsening oxygen, increasing ventilatory demands, a new progressive infiltrate on the chest X-ray, ball showing you 10 is to power 4 coloniforming units per ml of growth. When you do a biofire, it shows you a higher burden monomicrobial growth which is concordant with your culture, and your patient is improving in response to your active therapy. What would suggest a colonization would be that there is no respiratory syndrome, but you're growing multiple bugs, and there is a low count growth, and your patient doesn't require antibiotics. You're dealing with something else. Then if the intra-abdominal infections, like I told you initially as well, you need to drain the abscess in the intra-abdominal collections. You need to relieve that obstruction. You cover always for enterobacterials and anaerobes. TG cycline and ervacycline are great drugs for intra-abdominal infections. You give a short course if the source is controlled, and longer if inadequate source control. Little pain. Just in brief about the two drugs, colistin and polymyxin B. So They are best avoided if alternatives exist because of the potential of nephrotoxicity and neurotoxicity.
Paracetamol,
Now,
Betnisol,
when you use them, you must give a full loading dose. Always for colistin, always give 9 million units followed by 4.5 BD. And for polymyxin B, always give 15 lakh units followed by 7.5 BD. When you're giving colistin to a patient of AKI, if you really have to, then you must monitor the renal function closely. Avoid monotherapy for severe infections, especially when better combinations exist. And there is a tendency to use a lot of nebulized colistin for a lot of patients with pneumonias. Alone monotherapy, you should not be doing that. They should always be only used as adjuncts if really needed. Then, since we are going to be talking about ESBL and AMCs, let us understand the ESBL enterobacter is. So, ceftriaxone resistance is the clue. How I will tell you. What is ESBL? ESBL is plasmid-mediated enzymes, commonly CTXM, TEM, and SHV variants. What do? They hydrolyze the third and fourth generation cephalosporins as well as astronam, and they spare carbapenems. They spread horizontally across E. coli, Klebsiella, and Proteus species. So, ceftriaxone is a non-susceptible. CTXM on molecular panel strongly supports. Double disc synergy tests, that is your clavulinate synergy, can confirm ESBL, and AMC can masquerade an ESBL. So you have to look at the organism and cefoxitin. Let us understand this. Beginning with the double disc synergy test. So if you look at these two large discs and one in the center, one has ceftazidime, the other has cefotaxime. Now ESBL would inhibit. So it would basically inhibit your third generation. They hydrolyze basically your third generation cephalosporins, and this disc contains clavulinate, which will inhibit ESBL enzymes. So what happens is you see that this zone of inhibition, which was initially very, because this is a picture taken a little later, this may be initially very small, but with the presence of this clavulinate inhibiting the ESBL, there is it is causing expansion of this cephalosporin inhibition zone. You can see over here, this is the expansion. So, sorry. So this basically tells you that that clavulinate has the capacity to inhibit ESBL enzymes, and it would cause expansion of the cephalosporin inhibition zone. So this tells you this is basically the double disc synergy test, which is the classical phenotypic test. But these days in the labs, most of the time they use molecular tests or MIC patterns, and you would often not see this. So this is basically to identify the ESBL clue. This is one of the classical tests which was done, which is the double disc synergy test. Then when you have ESBL, there is a possibility of co-resistance. So do not assume that all oral options are good to go. However, these are available and can be used if susceptible. That is your fluoroquinolones, trimethoprim, sulfamethoxazole, aminoglycosides, fosfomycin, as well as nitrofurantoin. So when we look at the ESBL UTI for uncomplicated cystitis, your drug of choices are nitrofurantoin or trimethoprim sulfamethoxazole if susceptible. For pyelonephritis or complicated UTI, trimethoprim sulfamethoxazole or fluoroquinolone is susceptible. Otherwise, ertapenem or meropenem. Remember, nitrofurantoin or fosfomycin should not be given. For sepsis bacteremia, meropenem if critically ill, ertapenem if stable and normal albumin. And you can step down to again trimethoprim sulfamethoxazole or fluoroquinolone when the patient is stable, the source is controlled, and of course the gut is working to accept the oral therapy. Then ESBL bacteremia after the UTI, we look at the ESBL bacteremia. So in critically ill patient, the drug of choice is meropenem or imipenem celastin. And if you are considering OPAT therapy for a stable patient, then ertapenem is a good choice, but it is best when the source is controlled and the albumin is normal because this has a high protein binding affinity. bloodstream infections, do not use in ESBL bacteremia, do not use nitrofurantoin, oral fosfomycin, doxycycline, co-amoxiclav, and I just told you piptazo, despite of your report showing sensitivity, because it was given with the Merino trial. As you can see very clearly, piperacillin tazobactam was associated with a higher mortality of almost 12.3% when compared to meropenem, which was only 3.7%. So the bottom line is use carbapenem for ESBL bacteremia. Why does it fail? Why did piperacillin tazobactam fail despite of it being susceptible on the report? Because susceptibility testing uses a low standardized inoculum, and in deep-seated infections or bloodstream infections, they have a much higher bacterial burden. So for ESBL bacteremia or severe infection, you must choose from meropenem, imipenem, and ertapenem if the patient is stable and the source is controlled. Now, you cannot use cefepime for uncomplicated cystitis, pyelonephritis, complicated UTI, bloodstream infection, pneumonia, and systemic, because ESBL can hydrolyze cefepime. So your drug of choice becomes carbapenem. Again, do not burn your hands on new BLIs for ESBL when carbapenem works. You need to use strategies to preserve Cas-AV and cefdiericol, especially when you know that your isolate is susceptible to carbapenem. After the ESBL, the next thing that we're going to look at is the AMC beta lactamases. So ceftriaxone may look susceptible, but may fail on therapy. Because AMC can be inducible, the organism may be susceptible to ceftriaxone, but while start on therapy, it will become resistant. Classically, it is seen with Enterobacter cloacae complex, Klebsiella aerogenes, and Citrobacter frundi. Third generation cephalosporins are risky for invasive infections in moderate risk AMC producers. And cefepime then is useful because it is a weak inducer and a poor AMC substrate. So what are the basic AMC mechanisms? Inducible chromosomal AMC, that is starts susceptible but becomes resistant. Stable depression, that is constitutively high AMC from mutations. And plasmid mediated, it is always expressed and can occur in E. coli and Klebsiella. So your cefoxitim resistance E. coli is a red flag when it's a plasmid mediated AMC. So the practical algorithm for all that I just said is that if you have double disc synergy test positive, ESBL is confirmed, treat as ESBL. Double disc synergy test negative, cefoxitim resistant, AMC is likely. E. coli with cefoxitim resistant, plasmid AMC possible, confirm MIC and co-production. Cefoxitim resistant, cefepime MIC more than 4. So it's a susceptible ESBL co-production, ESBL co-production, and the drug of choice over here becomes your carbapenem. So when you have a patient with AMC, what would you avoid? You avoid treatment with ceftriaxone, cefotaxime, ceftazidime, especially for invasive moderate risk patients. Piperacillin tazobactam, astronam monotherapy, and cefamycin as treatment despite cefoxitin testing. Preferred options for AMC treatment become cefepime if and only the MIC is less than 2, the source is controlled, and the inoculum is low. Meropenem and ertapenem become the drug of choice for invasive, high burden, incomplete source control or patients with cefepime MIC more than 4. And of course, trimethoprim, sulfamethoxazole, and fluoroquinolone is step down if the patient is stable and the isolate is susceptible. You must always reassess for the ESBL co-production. So to summarize again, the 3 AMC rules are: if the MIC is less than 2, the source is controlled and the inoculum is low, cefepime becomes your drug of choice. High inoculum or uncontrolled focus, choose meropenem, even if the cefepime MIC is less than 2. And rule 3 is cefepime MIC more than 4, cefoxitim resistance, think of ESBL co-production, and then your drug of choice becomes again a carbapenem. What about de-escalation and the duration of therapy and IV to oral switch? So, you switch from IV to oral. This rule follows everywhere. Your patient has to be stable. The symptoms have to be controlled. He should be hemodynamically stable. If you're choosing an oral switch, the gut absorption should be intact. You should ensure there is no deep-seated or an uncontrolled focus or source of infection that is still unattended. And for uncomplicated gram-negative bloodstream infection, 7 days of therapy is enough. Similarly, for VAP, often 7 days is enough if the patient is improving. Longer courses may be needed for patients with abscess, CNS infections, and if there is an inadequate source control. So, to end the talk, treat the syndrome and not the culture report. MDR risk factors decide empiric therapy, and cultures decide de-escalation. Ceftriaxone resistant E. coli or Klebsiella in bloodstream infection, you have to think of ESBL, and carbapenem becomes your drug of choice. Peptides are susceptible on report is a not reliable drug for ESBL bacteremia. Cefepime is usually avoided for ESBL invasive infections, but can be useful for AMC, especially when MIC is less than 2, source is controlled. Tigecycline is not the drug of choice for bloodstream infections. Nitrofurantoin and fosfomycin should not be used for pyelonephritis or bloodstream infections. BioFire gives you rapid clues, helps you to start early therapy, early targeted therapy, but it is not a substitute for your culture and AST testing. You must send that. Colistin and polymyxin Bs are toxic and they should not be your reflex choices, especially when other drugs exist which are susceptible. And persistent infection means you have to actively search for the source and not just have a reflex knee jerk reaction that your antibiotic is not working. You have to look at the drug also, you have to look at the site, the syndrome, the patient. If you selected a drug which does not penetrate your site of infection, the patient is not going to get better. So, changing the antibiotic is not the only way to treat the patient. So, treat the syndrome, control the source, interpret resistance, and de escalate appropriately. Thank you.
Thank you, Dr. Akansha, for giving a wonderful presentation on the approach to gram-negative infections. So, we start today's webinar, and that is on the carbapenem resistance. And I have a great pleasure to introduce Dr. Hemlata Arora, who is a DNB medicine and board certified USA in ID. He's FRC from UK. She is currently working as a director internal medicine Nanavati Max Super Specialty Hospital, Mumbai. She is director of internal medicine and DNB faculty, founder and head HIV and AIDS clinic, founder and head adult immunization clinic, and founder and head breast care clinic. She's won Paul Born Award, Sunny Upstate Medical University, New York, and her area of interest are lifestyle diseases, preventive health, critical illness, and infectious disease. Over to you, Dr. Hemlata Arora, to conduct today's proceeding.
Yes, thank you very much for this wonderful introduction. I would like to now open the session for the gram-negative infections module 2, which we're talking about we're proceeding to talk about the carbapenem resistance and its, the mechanisms as well as detection methods. So to give us a first section, I'm going to introduce a wonderful consultant, Dr. Parikshit Prayag. He is a consultant in transplant and infectious disease KM Hospital, Pune, and at Mangeshkar Hospital, Pune. He holds multiple professional positions and roles. He's a member of the Governing Council, Clinical Infectious Disease Society of India, member of the Transplant ID Committee, Clinical Infectious Disease Society of India, ID and Microbiology Committee, editorial board member of the Journal of Clinical Infectious Disease Society, is a member of the Fungal Infection Study Forum India. So he's well versed with the Infectious Disease Society of the country, his academic achievements. He's an author of numerous peer-reviewed publications. He's contributed 18 book chapters and is the editor of 3 medical books. He is a well-honored and accomplished physician. He has a presidential citation and the ISCCM, the Young Achiever Award in the Indian Medical Association. His area of interest are transplant infections, fungal infections, and gram-negative resistance. I'd like to introduce Dr. Parikshit Prayag to go ahead and conduct this session on mechanisms of carbapenem resistance. Thank you, Dr. Prayag, for being here.
Yes, thank you, Dr. Arora. Thank you for the kind introduction, and thank you, Akanksha, and thank you, Chawla sir, for this kind invitation. I have heard great things about the course, so I hope I can do my bit this evening.
Since when?
Okay, I hope my slides are visible.
Absolutely.
Yes, thank you, sir. So good evening once again. Thank you to all of you who have joined in. I'm going to be talking about mechanisms of carbapenem resistance. Akanksha has set the stage by talking about ESBLs and AMCs, and so we'll continue this journey in the increasing order of complexity. You know, if you look at gram-negative organisms, and if you look at what produces carbapenem resistance or what makes them resistant to carbapenems, you will see 4 important factors there. So normally what happens is that if you look at a beta-lactam, then this beta-lactam is going to enter through this porin channels, and then it is going to bind to our penicillin binding proteins. Remember, different beta-lactams bind to different PBPs, and that is their job in life. Their job is to disrupt the formation of the cell wall by binding to the penicillin binding proteins. Now, during this journey, there could be resistance seen at 4 important places. One is that you see this red modified porin channel here. So our beta-lactam antibiotic is not able to enter at all. And that is seen sometimes in cases of Pseudomonas. I'll come to various mechanisms this evening. So this is our modified or mutated porin channel. Then you could have efflux pumps, which means that, you know, instead of continuing their journey towards the penicillin binding protein, these beta-lactams are going to be effluxed out or kicked out of the gram-negative organisms. Then you have beta-lactamases, which again are enzymes that destroy our beta-lactams. We've heard greatly about AMCs and ESBL, so I'll be talking about carbapenemases. And then last but not the least, you could have a modification in the penicillin binding protein itself. So what that means is that the final target is mutated, and that's why your beta-lactams won't be able to act. So if you look at beta-lactam resistance, then these are the 4 main ways in which a gram-negative organism can become resistant to beta-lactam antibiotics. So I'm going to be focusing on carbapenem resistance this evening, and if you look at, you know, with these various enzymes, you could have penicillinases, you could have AMCs, you could have ESBLs, and then you could have carbapenems, is what we are going to focus on. A more formal way of structuring or classifying these enzymes is this Amler's classification. So as you've heard so far, you know, this Amler's classification talks about different classes A, B, C, and D. Out of these, we have carbapenemases in class A, B, as well as D. Now, B is different because these are metallo-beta-lactamases. The other 3 classes are serine-beta-lactamases. I'm not going to be talking about class C because because that class mainly contains AMC enzymes. So if you look at carbapenem resistance, or from the point of view of carbapenem resistance, I'm going to be talking about class A, B, and D this evening, and then we'll go over and see some of the non-enzymatic mechanisms of carbapenem resistance, and in the last maybe 5 or 7 minutes, I'll throw some light on some atypical mechanisms of carbapenem resistance, what we are increasingly seeing in our atypical non-fermenters, so organisms like Stenotrophomonas or Elizabethingia, Ralstonia, and so on. So let's start with class A. So if you look at this Amler's class A, Amler's class A has many important ESBLs. So you have the STEM, SHV, CTXM, which are important ESBLs of Enterobacteriaceae. You also have Per and Web, which are important ESBLs of Acinetobacter and Pseudomonas. But what we are going to focus on is the carbapenemases. So if you look at group A or class A carbapenemases, then you have KPCs, GES, SNEPs. So KPCs and GES are the important carbapenemases of class A. So if you look at an enzyme like KPC, luckily it's not endemic in India, whereas if you look at most of the carbapenem resistance, which is there in the Western world, especially in the US, you will see that about 80% of the carbapenem resistance for Enterobacteriaceae in the Western world actually comes from KPCs. In India, KPCs are sporadic cases, which means every now and then you might find one case of KPC, but it's not an endemic enzyme by any stretch of the imagination. In the last almost 500 isolates of Klebsiella that we have been genotyping now for the last 7 or 8 years, we've just found one KPC producer. That's not to say that it's not there at all. Depending on where you're practicing in the country, you could see some occasional variation. But by and large, KPC production remains very, very rare in our settings. So if you look at KPCs, there are different subtypes of KPCs, KPC1 and 2, which are clinically very, very important. And anytime you talk of an enzyme, what we really need to look at is that which are the organisms that produce this enzyme, what is the substrate profile of this enzyme, which means that which are the beta-lactams that this enzyme is destroying, and what is the BLI profile or the BLI spectrum, which means that which are the beta-lactamase inhibitors that we have in our repertoire, which are going to try and inhibit this enzyme that we are talking about. So if you talk of KPCs, then KPCs are carbapenemase, and if you look at the BLI spectrum of KPCs, or if you ask the question that which are the BLIs which are able to inhibit KPCs, sulbactam, azobactam, even the newer one, enmetazobactam, and clavulanate. None of these four are able to inhibit the KPC enzymes. The newer BLIs work, which means avibactam, relebactam, and vaborbactam work. In fact, avibactam, relebactam, and vaborbactam are the most potent BLIs against KPCs. Now, we don't have relebactam and vaborbactam here in India, and that's for a good reason, because we don't have too many pure KPC producers. Otherwise, relebactam and vaborbactam, which are combined, so imipenem, relebactam, or meropenem, vaborbactam, as you have in the Western world, these are good drugs to take care of KPC producers. In the last few years, there have been some cases which have reported mutations in the KPC, which have rendered avibactam ineffective. So, but these are few and far in between. So you have certain mutations there which can sort of reduce the efficacy of avibactam when it comes to inhibiting the KPCs, but these are not common by any stretch of the imagination.
No, sir.
Now let us look at the patient. Let's look at a patient like this. This was the 43-year-old gentleman we had last year with AML, undergoing induction chemotherapy. He developed febrile neutropenia. The lab informed that he has GNP in the blood, and this isolate was identified as Pseudomonas by Maldi. And sepsis flu, I'm sure Neha is going to be talking about ways by which we can identify these enzymes. So PCR-based analysis was done, and it is saying that the organism identified as Pseudomonas and the resistance marker identified as JES. Now, it's not a very common enzyme, but every now and then in the setting of Pseudomonas, you will see this enzyme JES in the Indian scenario. So it is a pretty potent carbapenemase, but not always, which means that there are various subtypes of JES, and not all of them will be carbapenemase. So if you look at there are almost 25 variants of JES. So if you look at some of these early variants, you will see that they are ES based. So JES 7, 8, 9, or 11, 12, 13, these are ES based phenotypically. Whereas JES 1 to 6 and the later ones, so 14 to 22, these are obviously, of course, carbapenemases. Now, when you have a PCR-based test, it really doesn't tell you the subtype or the variant of JES that we are dealing with. So if I were seeing this patient today, just based on this information that I have a Pseudomonas aeruginosa in front of me, and there is a JES production there, I will not be able to really predict for sure whether this is going to be a carbapenemase JES or ESBL JES. But in our settings, it is very likely to be a carbapenemase. Remember, there are more JES variants which are carbapenemases than ESBL JES variants. And if you again look at the the BLI profile of JES, then you will find that avibactam, for the most part, is a good BLI against JES. But there are certain JES variants, which have been found to be concerning. I'll get to that a little bit more when we talk about some rarer things and some other aspects of Pseudomonas. But the bottom line is that JES can be an important carbapenemase. It's a class A carbapenemase. For the most part, it's going to be a carbapenemase. There are few variants which could be ESBLs, and avibactam is a good BLI against it. But you could rarely have this variant or this type where avibactam is unable to inhibit our JES enzyme, which is there in front of us in the patient. Now, if you look at class B enzymes, of course, you must have heard a lot about class B enzymes. These are your metallobeta-lactamases. These are the most potent ones. Remember, their location in these bacteria is different, their structure is a little different, the way they function is a little different, and there are various types of class D enzymes. So the most notorious one out of this is the New Delhi metallo-beta-lactamase. So this New Delhi metallo-beta-lactamase, again, there are many variants of NDMs which have been now well described. NDM5 has been in the news in the last few years. But bottom line is that these are very potent enzymes. They hydrolyze all our beta-lactams except astronam. So as you can see here, except astronam, all the beta-lactam-amines are on the higher side. Now, if you look at the geographic distribution, unfortunately, India is a place which is endemic for NDM producers. And this was actually described in a Swedish patient who was backpacking in India and developed Klebsiella infection, and then they found that this was a different enzyme which was genotyped to be the New Delhi metallo-beta-lactamase. Now this is a metallo-beta-lactamase, it's a zinc-based enzyme. So really a lot of the BLIs that we use in clinical practice, almost all of them, don't work against the New Delhi metallo-beta-lactamase. So of course, tazobactam, enmetazobactam, clavulanated sulbactam, they don't have any activity. But even avibactam, relibactam, and mevobactam, they have no activity against the metallo-beta-lactamase. Even zidibactam, which is supposed to be there probably by the end of this year or early next year, has no activity by itself when it comes to the inhibition of New Delhi metallo-beta-lactamase. Taniborbactam would perhaps be the first meaningful BLI to be able to inhibit the New Delhi metallo-beta-lactamase. And except ceftriaxone and astronam, all our beta-lactams will be hydrolyzed pretty potently by the class B enzymes or the New Delhi metallo-beta-lactamase. As I said, when it comes to the BLI spectrum, then there is very little to offer in terms of the BLI. Even zidibactam is not going to be New Delhi metallo-beta-lactamase. So it's a problematic enzyme. If you look at IMP and VIM, again they are also pretty important enzymes in our sector. And there are various variants again of IMP. So you see the sort of global IMP distribution. This was a beautiful article which was published recently. So if you look at the global distribution of IMP, then you will see that there are certain variants which are more common in India. So IMP1 is a fairly common variant that we get. Some of our pseudomonas isolates do produce this IMP. So these are also important enzymes, but by and large they have common properties when it comes to the class B enzymes. Now what about the OXA enzymes? So if you talk about the OXA enzymes, then the first family, if you can use that word, or the group of enzymes that you want to talk about this is this OXA48 ligand. Now remember, this is a group of enzymes. And most of your PCR-based tests are not going to really tell you which subtype of OXA48 you're dealing with. So these tests are going to club it together and describe them as OXA48. So what are these OXA48-like enzymes? So these are class D carbapenemases, and which organisms produce these? These are mainly produced by Enterobacteriaceae. What do you mean by Enterobacteriaceae? These are our fermenters. So E. coli, Klebsiella, or Citrobacter, Enterobacter. So especially E. coli and Klebsiella are pretty heavy producers of OXA48 in our settings. Now if you look at this OXA48-like enzymes, then as I said, there are various variants or various subtypes here. If you look at the pure OXA48, then it may be able to spare ceftazidime, which is fine. But if you look at some of the other ones, for example OXA162 and OXA181, even OXA232, these are particular subtypes which are quite notorious for very potent hydrolysis of carbapenem. So whereas OXA163, that's a very weak carbapenemase. So which means that if my sepsis flow or a PCR based test tells me that OXA48 is present, and this isolate actually turns out to be a cephalosporinase but not a carbapenemase, then it is very likely that there is OXA163 present there. So these are different variants of OXA48 which could be seen in the clinical practice, and that's why you will see some variations when it comes to the phenotypic resistance and in the face of OXA48 production. OXA181 again, which is very common in India. In fact, if you trace the epidemiological studies of OXA181, or if you trace the geographical distribution of OXA181, what you will find is that it pretty much mirrors this spread of the New Delhi metallo-beta. There is again one other interesting aspect here. It is, a more potent hydrolyzer of imipenem than meropenem. Guess what? There are mutated OXA 181s which have been described, especially from Eastern Asia, which also show the reverse pattern. So, which means that you could get some discrepancy in imipenem and meropenem hydrolysis. So, if you see an E. coli, which is cephalosporin resistant, which is ertapenem resistant, and there is some discrepancy between meropenem and imipenem, that the MIC of one is a little disproportionately higher than the MIC of the other, which means that there is an enzyme which has affected imipenem more than meropenem. Then you could very well be thinking of OXA 181. Remember, the enzymatic test that you will perform in this type of a patient will give the report as OXA 48 enzyme present, because these are all clubbed together as OXA 48 like enzyme. But there are subtle differences in these patterns, call them that way. Avibactam is a very, very good inhibitor. So against all these subtypes, again there are very sporadic case reports of sort of OXA 48 mutating in such a way that avibactam becomes refractory. But other than those sporadic or isolated case reports, you will find that pretty much almost always avibactam is a potent inhibitor of OXA 48, which means that if you don't have NDM production, your ceftazidime avibactam by itself should be able to take care of the OXA 48 producing enterobacterium. Then if you look at the other carbapenemase oxals, then it is pretty much exclusive to Acinetobacter. So if you look at Acinetobacter, there are 4 carbapenemases which are oxals which are important. So Acinetobacter is capable of producing 4 oxacarbapenemases. So you have OXA 23, 24, 51 and 58. Out of these, OXA 23 is epidemiologically as well as in terms of potency very, very important in the Indian settings. I'll show you some of our own data later on that OXA 23 is a very, very important enzyme in our settings. OXA 51, although it is termed as the carbapenemase, may not always be a carbapenemase. It needs some kind of changes in the promoter regions upstream for it to become a carbapenemase. And in my experience, in the last 7 or 8 years, whenever we have found OXA 51, although it is termed as a carbapenemase, very rarely have we seen that it is actually phenotypically a carbapenemase. So although these 4 enzymes, 23, 24, 51 and 58, are termed as Acinetobacter oxacarbapenemases, 23, 24 and 51 are by far more potent, and 23 geographically, epidemiologically in India is a very, very important enzyme. So that makes it slightly easier to remember the oxacarbapenemase. So you have OXA 48, which is an enterobacterial carbapenemase, and then you have 23, 24, 51 and 58. And more importantly, if you just had bandwidth to remember one out of those 4, it would have to be OXA 23, which is a very, very potent Acinetobacter carbapenemase. Now, what about the avibactam profile when it comes to these type of enzymes? So we looked at KPCs, we said that many bugs produce it, but it is rare in India. Is it inhibited by avibactam? The answer is yes. NDM class B enzymes, many different organisms produce it. Unfortunately, far too common in our settings. Is it inhibited by avibactam? The answer is no. Not just avibactam, but even zidibactam or vaborbactam, regibactam, none of the BLIs which are currently available in clinical practice offer any type of inhibition when it comes to the New Delhi metallo-beta lactase. OXA 48, we said, is a group of 163 is something wherein you will see weak activity. 162 is where you will see potent carbapenemase activity. 181 is where you will see some imipenem, meropenem discrepancies. 232 again is an important enzyme in India. 181 mirrors the spread of NDM. So OXA 48 is quite a distinct family. It has some variations there, but by and large you can say that it is a carbapenemase family, and by and large you can say that it is produced by Enterobacteriaceae, and definitely it is inhibited by avibactam. And then you had the 4 Acinetobacter carbapenemases, which are OXAs 23, 24, 51 and 58. And we said that 23 was by far the most important one, and none of these are inhibited by avibactam. So if you look at the Acinetobacter carbapenemases, Acinetobacter usually either produces NDM or these oxals. None of them are inhibited by avibactam. So that avibactam is a very poor choice when it comes to Acinetobacter. Add to this the fact that Asteunam offers very little in terms of anti-Acinetobacter activity, and that's why you will see that the combination of ceftazidime avibactam plus Asteunam really is not a drug for carbapenem resistant Acinetobacter. Now, what about our own enzymology, if we can use that word? If you look at our Klebsiella, then our Klebsiella is more of a multiple enzyme producer, which means that a lot of our isolates commonly produce 2 to 4 enzymes: CTXM, NDM, OXA48, as well as SHVs. We get this pattern quite a bit in our hospital, that all these 4 enzymes are produced. If you look at E. coli, then it is less of a multi-enzyme producer, and a large number of these isolates also produce NDM. So there are some differences in the enzyme patterns of Klebsiella versus E. coli. If you look at our Acineto, like I said, OXA23 and NDM are quite important enzymes in our practice. Still, almost 50%, in our study, close to 46% of the isolates produced NDM. So that is a very, very important finding, because down the road you will have something like Durlobacter, which is able to take care of the Acinetobacter oxas. Remember, I said that right now we don't have a BLI which is able to take care of the Acinetobacter oxas, so 23, 24, 51, and 58. But soon you will have Durlobacter, which is able to take care of the Acinetobacter oxas. Still, half of our isolates will remain problematic, because as you can see from my study here, at least half of our isolates are still producing NDM, and there your Durlobactam is not going to help you. So that's why it is very, very important to recognize what patterns we have, and that is what helps us in trying to decide whether Western guidelines are applicable in our settings or not. Especially if you look at gram-negative guidelines, you will see a number of things there which may not be exactly applicable to our settings, because our problems are very, very unique. Unique is a very nice way of putting it. Our problems are really very, very wretched when it comes to gram-negative resistance. Now, moving away from the enzymes are not the only things that are responsible for carbapenem resistance. You have mutated porin channels. So look at this Pseudomonas. Look at mutated porin channels and look what they do to imipenem and meropenem. Traditionally thought to be resistance mechanisms which affect imipenem more than meropenem, but you will see variations depending on some mutations in these type of porin channels. And then you can also have efflux mediated resistance that holds true more for the cephalosporins, but some of the efflux mutations can also bother your carbapenems. And especially when you have something like an NDM plus an efflux mutation, that makes things very, very challenging in the Indian setting. Let us look at this type of patient here, a 30-year-old male with AML who was post his induction chemotherapy, developed a fever, blood cultures were sent, was started on piperacillin tazobactam, raised procal, and GNB was detected. The sepsis flow was done. I'm sure Neha is going to be talking about ways of identifying these different enzymes. And the markers detected were SHV, CTXM, and NDM. But the ceftazidime avibactam aztreonam synergy was not detected. And this is again a problem. Carbapenem is producing E. coli, you have NDM there, but so normally you would have expected avibactam to take care of the SHV and CTXM and clear the path for aztreonam. NDM again wouldn't hydrolyze aztreonam, so you would have expected the aztreonam to go and kill the E. coli, but that's not happening. The reason is that you could have mutated PBPs, or there could be certain PBP inserts. Now remember, a lot of the E. coli isolates actually carry these PBP inserts. So it's not that the presence of a mutated PBP or a PBP insert is equal to aztreonam resistance. It really depends on what type of mutation it is and what the enzyme profile is. If you look at some of these, then if you look at an insert like a Wyric balloon, that could be damaging. But if you look at something like Wyrin, and these are different inserts that you see in this PBP3, then it will really depend on what the other enzymes are. So usually, NDM plus CMY42, we just heard in the AMC talk, so NDM plus CMY42, other enzymes like CTXM, and then the presence of these PBP inserts, that's quite a damaging combination. So you will see some of our isolates. So in our own settings, about 25% of our E. coli isolates fail the synergy test. It could be higher or lower in your own hospital depending on where you're practicing, and that's why it is important to test for the synergy. Now we have aztreonam avibactam strips as well, so it's important to look at the aztreonam avibactam MICs and kind of confirm when it comes to E. coli. With Klebsiella, the chances of going wrong are far less than those are with E. coli. Look at this isolate here. Pseudomonas in blood cultures, it is resistant, to BLBLIs. It is resistant to carbapenems. It is also resistant to astrolam. Ceftazidime avibactam is also resistant. So there could very well be a presence of endium. Everything is resistant. In Pseudomonas, funnily you will get non-endium isolates also which look like this. So for example, if I have a Pseudomonas which is producing a purr or a web, and then it has mutated porin channels, it might look exactly like this, because purr and web are enzymes which are ESBLs of Pseudomonas, and avibactam is not particularly potent against them. So an ESBL of Pseudomonas plus a porin channel mutation also might look exactly like this. But here we are likely to have NDMs. A lot of our pseudomonal isolates have NDMs, and Cas-Avi plus Astronam synergy is resistant. So the question is that in our CR pseudomonas or carbapenem resistant pseudomonas, remember anytime carbapenem is resistant, it is called carbapenem resistant. Whereas if it is producing a carbapenemase, it is called a carbapenemase producing or a CP. Whereas CR is carbapenem resistant. So we know for sure that this is CR. Whether it is CP, we don't know. Like I said, you could rarely get some ESBLs of Pseudomonas with a porin channel mutation, which also look like CP isolates, but they are actually not CP, they are CR isolates. Now, if you look at this type of a Pseudomonas, it is failing the synergy of Cas-Avi plus Astronam. So, what could be the reasons that this Pseudomonas is failing the synergy? Now, one important reason is the efflux pumps. So, although traditionally you would have expected avibactam to take care of, let's say, the AMC that was there, and Indium, you would have expected Astronam to work there. The combination is not working because of the efflux pumps. But remember, efflux is not the only way in which you could have problems when it comes to the combination of Cas-Avi plus Astronam. So if you look at the important enzymes of Pseudomonas, not just carbapenemases, but if you look at the important enzymes of Pseudomonas, you have KPCs, but more in the Western world. We have carbapenemases, very much important in India, which are class B carbapenemases, so Indian women in. Jess, as I told you in the beginning of the talk, some of our Pseudomonas isolates, I can remember at least 3 in the last year, which have been Jess producers. Per and Web are ESBLs of Pseudomonas. So if you look at all these enzymes, then Per, Web, and of course your class Bs are not well inhibited by avibactam. So which brings us to the question that, what are the possible mechanisms when the Cas-Avi Astronam synergy fails for a carbapenem resistant Pseudomonas? So like I said, one could be efflux mediated resistance, wherein the synergy of Cas-Avi Astronam is failing. There could be others as well. So for example, you could have certain Per and webs there, wherein the avibactam is not going to be able to take care of them, and they in turn are going to destroy our Astronam. You could have certain Jess variants, like I said in the beginning, there are certain Jess variants which are refractory to inhibition by avibactam. So avibactam may not be able to take care of all the Jess variants. So look at this Spanish study here. There were 9 Cas-Avi Astronam resistant Jess producing Pseudomonas. 5 of these were Jess 20. There are others as well, Jess 19, Jess 26. These are also not very forgiving subtypes when it comes to avibactam inhibition. And then there could be, certain OXAs like OXA 10, which could be a problem. Some KPC variants could be a problem. So there could be various reasons due to which the synergy of Cas-Avi Astronam is failing, largely because of efflux. But remember, efflux is not the only reason why, such synergy will fail. Now, look at this patient here. He is having stenotrophomonas in the blood, and it is carbapenem resistant. So the question is, can we ever use carbapenems for stenotrophomonas? The answer is no. And the reason is that they have these important enzymes in them. So this L1 is a metallo-beta-lactamase. It is like your NDM. So it's a metallo-beta-lactamase, and L2 is a cephalosporinase. So L2 is, let's say, like CTXM. So L1, L2s are present in the stenotrophomonas, and that's why Astronam avibactam is actually a very, very potent combination for stenotrophomonas. It's just like having NDM plus CTXM. So when we have NDM plus CTXM in our Klebsiella, we expect avibactam to take care of CTXM and Astronam to be not affected by the New Delhi metallo-beta-lactamase. And that's why if you look at Astronam avibactam susceptibilities, this was a very large study in which they looked at almost 1800 isolates and look at the Astronam avibactam susceptibility for stenotrophomonas. I don't need to say CR stenotrophomonas, steno is always CR. So if you look at this, because of the fact that avibactam is a potent BLI against the L2 cephalosporinase. But he still broke through on it, and when you have this type of a situation, essentially, you are dealing with flux-mediated resistance. So that's why, there will still be the odd isolate where Astronam might be resistant when it comes to stenotomy.
Okay.
What about Elizabeth India? Elizabeth India is, we are unfortunately seeing quite a few cases in our ICU when it comes to Elizabeth India. So it has important metallo-beta-lactamases. This Blabi and Bob, these are important metallo-beta-lactamases of Elizabeth India. That's why you will see. So for example, in one of our recent publications, we had 20 isolates of Elizabeth India, bloodstream isolates causing bacteria, and 100% carbapenem resistance. So metallo-beta-lactamases, Blabi and Bob, they confer resistance to carbapenems, whereas CME, they also have the extended spectrum serine beta-lactamase, CME, and that is associated with cephalosporin resistance. Now, anytime you have a combination of a class B enzyme with a class A enzyme, then you will expect both ceftazidime, avibactam, and aztreonam to fail individually, right? Because the class A ESBL-like enzymes will usually take care or destroy aztreonam, and the class B metallo-beta-lactamases will destroy or make your Cas-Avi effective. But anytime you have this combination, class A plus B, we saw that NDM plus CTXM, or L1 plus L2 in case of stenotrophomonas. Anytime you have this type of a pattern, you would actually expect your aztreonam avibactam to work. That doesn't seem to happen for Elizabeth B. So look at this study here. Aztreonam avibactam was not found to be susceptible in any of these carbapenem resistance. And there are various reasons. One has been that Blabi and Goff, they may not be, sparing Aztreonam convincingly. The other very, very important part here is that you could see you could have a situation where CME is actually not very well inhibited by avibactam at all. And then the potency of Aztreonam against the organism itself also is something to think about. See, at the end of the day, Aztreonam needs to be potent against the organism for it to work. So the bottom line is that Aztreonam avibactam doesn't seem to be a choice for any of our Elizabeth India isolates, despite the fact that you have a class A plus class B mediated resistance. So ideally, theoretically, it could have been a good situation. A recent patient, again, 64-year-old female with CA breast on chemo, started having fevers, was started on piperacillin tazobactam, blood cultures were sent, and lab called saying that all the 4 bottles are growing a GMP, was changed to meropenem by the primary team. Next day, the lab informed that the organism is Ralstonia. So what are the chances that your meropenem is going to work? The answer is unfortunately very little. So if you look at this Ralstonia, there are again 2 important enzymes which are actually class D enzymes, OXA60 and OXA22, and you will see that they are quite potent, especially OXA60 is quite a potent enzyme. So these are experiments in which they deleted that particular enzyme and then looked at the efficacy. So when they deleted OXA60, the MICs came down quite convincingly. So OXA60 is a very, very important imipenem hydrolyzing class D beta-lactamase. So you will very rarely see a situation, at least we don't see it, wherein your Ralstonia is carbapenem susceptible. They also have a fair amount of efflux-mediated resistance. So that's why when you have these type of atypical non-fermenters, you really need to go back to the basics and think about how this resistance developed before you even tell the lab to test for synergy, or before you make empiric changes in the therapy. So it's about 3 or 4 minutes past 8:30. So I'll summarize by saying that in E. coli and Klebsiella, NDM and OXA48 remain our major problems. But you have seen that there are emerging concerns when it comes to E. coli and Aztreonam avibactam, because you will see some of these isolates harboring clinically relevant PBP3 mutations. Like I said, not always does it mean that the presence of a mutated PBP is equal to E. coli Aztreonam avibactam resistance, but you could see that in certain situations depending on the type of mutation and depending on the other enzyme spectrum. Pseudomonas has many, many different mechanisms of resistance. Even if you look at carbapenem resistance, you have KPC as a class A enzyme there, you have class B, NDM, VIM and IMP, and you have efflux and porin mediated resistance as well when it comes to carbapenem resistance. So they have Pseudomonas isolates have varied mechanisms. Some of them are enzymatic, some of them are non-enzymatic. Acinato, usually in our settings, NDM and oxacarbapenems are the problem. And if you look at the non-fermenters, then each has its own unique mechanism of carbapenem resistance. We need to get familiar with that, and that will help us predict, whether our acetonamycobacterium is going to work or even should be tested versus the other choices like TMP, SMX, minocycline, fluoroquinolones, and so on that we have for these type of organisms. So I think I'll stop here again. Thank you, Akanksha and Chawla sir, for inviting me. And I look forward to the rest of the evening.
Thank you very much for this very wonderful and this talk, which has made a very complex topic. You've dealt with such clarity. I really appreciate this presentation. I want to now invite the next speaker, who is going to talk to us about the laboratory detection methods and clinical interpretation. That then would we be able to discuss some questions and answers after that. I'd like to introduce Dr. Neha Rastogi-Panda. She's a senior consultant in infectious disease at Fortis Memorial Research Institute in Gurugram, Manesar and Okla. She's a country ambassador for International Immunocompromised Host Society. She's a Working Party member, India representative for Infectious Disease Working Party. She's an associate editor for Transplant Infectious Diseases Journal. She's a global mentor for infections and transplant and CAR-T, Indian representative for the WHO TB Public-Private Partnership Learning Model. She's a lead for the TB STEPS program, Fortis Healthcare, and the Union Chief Organizer for the Forum of Infectious Diseases in the Immunocompromised. She's a convener for the Antimicrobial Stewardship Committee, excuse me, I don't know what happened here. Yeah. She has had a travel grant, an Indian representative for the ICFIP workshop, WHO headquarters in Geneva. She's a co-member of the CDC multi-centric capacity building project on infection prevention. She's had multiple publications, 46 peer-reviewed research publications, 5 book chapters, 108 conference abstracts. She's a professional member of the ESCMID, the ISHAM, the ASM, the ISCCM, and IAMM. So, we welcome our accomplished speaker, Ms. Dr. Neha Rastogi-Panda.
Thank you all. Good evening, everyone. First of all, I would like to thank Dr. Chawla sir and Dr. Akanksha. Thank you for the humble introduction, Dr. Arora. And moving on, for the laboratory detection methods, because Dr. Parikshit has beautifully explained about the mechanism of resistance, but in order to elucidate and in order to detect it, and we have to see first from the detection and then how we diagnose that what are the mechanisms being plausible, because at the receiving end, as a clinical personnel or for that matter even a lab personnel, and from the patient perspective, how we can detect those methods of those mechanisms of resistance, and of course implicate in our perspective for the antibiotic choices, of course, and the combination therapies eventually, and then of course the de-escalation approach as well. Hope my slides are visible to all. My slides are visible to all? Thank you. So I've just summarized because there are different cater, and this particular workshop and this particular protocols have been learned by a lot of people and have been appreciated in the past also. So why this is important? Because we need to have our own customized choices in terms of the beginning, and why when we say the interpretation matter, because breakpoints does matter. Just doesn't matter that the previous, we used to see those sensitivities where you have plus, 2 plus, 3 plus in different kinds of drugs. Everything is now about the breakpoints, and Dr. Parikshit has already explained that phenomenon. And then the similar pattern also importantly highlights us that what to choose in not only in terms of the drug choices, drug dosages also. The MIC, the minimum inhibitory concentration, and I'll come to that, also sometimes majority of the times defines what dosages has to be used, whether they have to be increased the dosages, what kind of kinetics they follow, so whether we have to have an extended infusions or a point time concentration, and of course the right timing. Then the similar patterns also helps us in de-escalating the rightly at the right time. And of course, many times we need to have another important aspect of the clinical interpretation is that suppose you have a X resistance mechanism. Infection prevention and control practices also many times depends upon that. If you have a CRE going on, if you have an ESBL going on, you need to have an MDR control precautions. So all these from A to E is dependent upon your laboratory detection methods and a detection of an X type of a resistance. And the point of the highlight for today is talking about the carbapenem resistance. So we all know, and I just want to reiterate the fact that the rates have already exceeded, and this is throughout. And if we talk about in our Indian settings, already being well explained by my previous speaker, that how the OXA 48 rules, and especially the New Delhi metallo-beta-lactamases or the group B metallo-beta-lactamases rules in the carbapenemases. And we are mainly talking about the enzyme activation pathways over here. Though there are mechanisms for the efflux pumps and the porin channels, but majority of the testing till date and the commonly used testing is also dependent upon the most common mechanism of resistance, which is the enzyme based production. Now this is, we all know that AMR in Indian context is very unique and challenging, and I just want to highlight few things. Specifically when we talk about enterobacterials, the most commons which we talk about is the E. coli or Klebsiella, and of course followed by our Enterobacter or a Citrobacter. In E. coli, now we have more of, apart from your routine NDMs and all, more of PDP3 inserts. We have all heard about a lot of plasmomycin going on in our thought process, and that is all because of this particular mutation. Now, how to pick up that mutation in the clinical scenario is something which we need to see. Klebsiella, we have lot of testing, both phenotypic as well as nowadays genotyping, molecular at bay, your biofires, syndromic panels, even the next generation sequencing, which will have a syndromic based diagnosis, not only in the form of the bug, but also in the form of a drug and a drug resistance. For pseudomonas, again, Dr. Parikshit has explained, so I'm just gonna repetitively mention about the efflux and the porin loss. And for the Acinetobacter, since majority of them are already resistant, the oxals and the NTM carbapenemases rules to show in the Acinetobacter bombinans. So I think this is very well noted for all of us, and I'll highlight the similar slide in the end also, when we have a more understanding upon their enzyme activation methods as well. So I think I'll just start upon directly with the case, and this is a 28-year-old male case who is a acute myeloid leukemia. He underwent a bone marrow transplant. Day plus 11, we have a post-transplant prophylaxis going on, and the patient develops the high-grade fever spikes with chills, which is a regular episode and a more predictable episodes in this kind of population, and we call them as a febrile neutropenia. So very high-grade fever, 101, tachycardia is there, and the neutropenia is at the peak. The absolute neutrophil count is barely less than 100. The line is in C2, line gets blocked, you get the paired blood cultures, and you start with particular sort of antibiotics, and most of the time that antibiotic choices also differs from center to center, and your antibiogram actually is a major determining factor in the what antibiotic you're gonna start next. On even the meropenem, the patient has a continuous fever spikes, and then eventually, most of the time, because we all know still date that the culture positivity rate is still not very up to the mark. It is still in the bleed zone of 40 to 50%. And in the febrile neutropenic category, that number also decreases to even 30%. So you add, most of the times empirically, you have a teicoplanin and colistin. Patient was still having fevers, and then after all possible workup, after almost 36 hours, blood culture still gives the signal which shows the gram-negative bacteria. Now the point of the view is that since fever was still persisting, patient developed hypotension on the existing antibiotic combination, and eventually we have to stop the meropenem because the antibiotic susceptibility testing is still taking one more day to come. And we added the estronam avibactam based combination which is available nowadays. And then the blood culture finally grew Klebsiella pneumoniae, which is multi-drug resistant and only intermediate cholesterol. Now on your right hand side, you can see this kind of a charting, which is our usual scenarios which we see. Most of the centers, I think majority, almost 99% of the centers follow the two-way approach, which I'm just going to discuss, that how we get the antibiotic susceptibility testing. Most of the centers use the diffusion based settings also. And of course, most of our tertiary referral centers use the automated center, of which the Vitek 2 is the most common variety. You have a Sensititer and the BD Phoenix, which is lesser being used. For the dilution, which is actually the gold standard for any susceptibility determination, is the agar-based dilution, macro broth, and the micro broth dilution. Very important in the bacterial as well as in the fungal and other organisms. But for the time being, since these are most easy to be used, first line of the antibiotic susceptibility testing which you comes to anybody on the bedside comes either with the disc diffusion with the proper zone-based diameter testing and the Vitek 2. The another important highlight is when you see the e-test or a strip-based test where you can find out the concentrations of those antibiotic for a particular organisms, and that we called as a minimum inhibitory concentration, which I'll just come upon. Now, what does this minimum inhibitory concentration means? That means that what is the lowest concentration of a particular antimicrobial agent in a unit of microgram per ml, which prevents that bacteria to be growing. Usually that can be 50% of the growth of bacteria, 90% of the growth of the bacteria, and most of the times in our settings we use the 50% MIC50, which is the concentration of antimicrobial agent at which 50% of your organism testing are inhibited. Now, what is the minimum bactericidal concentration? That is something which we actually define in our deep-seated infections, bacteremia. For example, in the beginning of the talk, we were discussing about the inoculum effect in the ESBL bacteremia. Despite being the patient is on the piperacillin tazobactam, there is no much response. So there we need to find out what is the minimum bactericidal concentration of that particular antibiotic, because the more is the inoculum. If your particular antibiotic is able to give more than 99% of that inoculum, then only it can be able to handle those high instituted bacteremias or even a deep-seated infections, including endocarditis or a CNS infection. Now, post-antibiotic effect is something that you have a persistent suppression of the bacterial growth despite the antibiotic is being removed for the system. Maximum times we listen this term for the aminoglycoside group. Now, what is the breakpoint term? Because when we highlight that particular testing, which I have just shown in the previous, and I'll just come to that again, this kind of a thing, how to go that in the interpretation criteria is, you have two ways. You have an epidemiological cutoffs, which is basically, there are two societies. One is the European based and one is the US based. So for the Europeans, it is a UCAST, which mainly says that how they define the inhibitory concentration for a particular antibiotic is that they have two populations. One is a wild type and the other is a selected type, and how we can distinguish between the two makes actually the breakpoint that this is the particular cutoff zone that antibiotic may work, and below that antibiotic may not work. Whereas for the CLSI, which is the Centrally Laboratory Standard Institute, which is most commonly we practices, is the clinical breakpoint. That is, what is that cutoff which separates the strain that there is a high likelihood of a treatment success at a particular number, from which that there is a high likelihood of a treatment failure. So if we see this kind of a graph, so if you see the ECOGs, it's just that you have a wild type which are pan-sensitive, and then there is a mutant type. So anything which differentiates between the two, the origin of the wild type and the mutant type, is your epidemiological cutoff. Whereas the clinical breakpoint is something where there is a differentiation from the high likelihood of the success, which we call in terms of susceptible, and which differentiates from the high likelihood of the treatment failure, which we call in the terms of the resistant. Now, I'll just give you a simple example that this is a 47-year-old male with the basal ganglia bleed. You have a mechanical ventilator being there for almost 3 weeks. Develops a nuanced worsening of the respiratory parameters. New infiltrates have developed on the X-ray chest, and bowel has grown Klebsiella pneumoniae 10 raised to power 5, which is a classical case of a ventilator-associated pneumonia. Now, this is your antibiotic chart, which is meropenem, fosfomycin, piperacillin, tazobactam, amikacin. Now, if you see these MICs, you have a sensitive criteria of that and a resistant criteria of that. So, based on that, you basically decide that as per the interpretation that which of the following antibiotic will be resistant, which of the following antibiotic will be sensitive, and which of the following antibiotic will fall into susceptible dose dependent, which is for very few antibiotics such as cefepime, and which of the following will be intermediate. So if we talk about the interpretative category definitions are that you have a susceptible, which means at a particular given concentration, for a particular antibiotic, you have appropriate dose and that results in a clinical efficacy. That means the drug is good, choice is good, site is good, and you have a clinical efficacy. Then come the intermediate that usually it attain the blood on a particular site level, but the response rates may be lower than that for the susceptible ones. Means you have to apply in that particular body site. So the best example we can give is even the tigecycline. We know it's a very good drug. We see almost all the antibiograms for all the resistant ones. But when it comes to the abdominal infections and skin and soft tissue, we know that the penetration of that drug is amazingly better than that compared to the other counterparts. And it is physiologically concentrated or whenever higher than a normal dose of the drug can be used. For example, meropenem in a central nervous system infections. Then comes the susceptible dose dependent. That means you need to have a dosing regimen which results in a higher drug exposure than the dose is actually built up for the breakpoint. So even though that is considered to be an STD, suppose that number is concentrated to be 1 gram, we need that the double the dose has to be required for achieving that in vivo efficacy for a particular. And then comes the resistant, of course, which is not inhibited by a usually achievable concentration. Now, imagine this same patient, which I have shown in the first question, that is an AML patient on transplant prophylaxis in a peri-transplant period with the febrile neutropenia growing the Klebsiella pneumoniae, which is only and only intermediate to cholesterol. Now, from the same patient, we take a next day growth. And this is like our own settings, what we do in a usual scenario. And then we put certain additional testing, which I'll just come, that what are those tests? So first you get a simple AST, which is an antimicrogram of your patient, which shows that this drug is susceptible, this drug is intermediate, and this drug is resistant. Now you need more data in the today's settings. That what next? What are the feasible combinations in this setting? Because you have only one drug which is intermediate, and that is cholesterol. And as Dr. Kansha said in the beginning, that you have cholesterol versus polymyxin monotherapy is not a very great drug of choice or a great thought. Second, this patient also had an acute kidney injury, so usually we prefer to defer about the cholesterol. Polymyxin B, we were little skeptical. Now, in today's era, we do have an options which are cholesterol polymyxin sparing for this kind of organism-based approach. So for that, you need a certain kind of a testing that can we detect the genetic resistance also? Can we detect what kinds of enzymes are there? And as we have heard in previous lecture, they have a direct implication on the antibiotic choices. So for example, what we talk about is the phenotypic or a genotypic testing of the resistance. So for the phenotypic resistance is that see an ability of a growth of bacteria, that okay, in the presence of an antimicrobial agent it is growing. In the presence of some enzyme-induced antimicrobial agent activation, it is growing. Genetic testing does mean that you are just detecting the resistant genes, that they are present or absent, which are directly colliding with the mechanism of that particular resistance. So I'll give you an example. So what are phenotypic testing, what we do? That you are seeing directly, so for the carbapenem if we talk about, you are seeing a direct carbapenem breaking up degradation products, and that degradation products you can actually detect by various mechanisms. You have this colorimetric testing change, where you can see a simple color change by seeing that how that enzyme is breaking. And based on that light detection, if that enzyme detection is getting higher and higher and the color change comes very quickly, you can see that the amount of carbopenidases are quite high. And then you see as a rapid set that yes,
That's why
this
whatever
particular
thing
enzyme
you
is
take,
present
it
and
will
you
go
cannot
inside.
use this
But it
particular
is not getting
carbapenem.
digest because of
The others are the
water.
ICT or the immunochromatographic card tests, which are easily available and they give the rapid diagnostics at the bedside. So if you have a culture growth positive, or suppose you have blood cultures are there and they have shown the growth positive in your packing method, then you can take, and if you can see you have a culture. So this is like a routine testing. When you have a positive culture, you plate it, you get a sensitivity testing, then you retest it, and then in next 48 and 72 hours you will get to know the entire mechanism. Now how to curtail that in 15 minutes is you get a colony growth, and then in the next few steps you have this kind of a right-based carba-based test testing, where you have a control line and you have the commonly forced, which Dr. Parikshit has mentioned, common forced enzyme-based carbapenimases prototypes, which is KPC, OXA48, Vim, Imp, and ND.
ಅವ್ರನ್ನ ಮಿಸ್
And
ಮಾಡ್ತಾರೆ
then you take the simple
20 ವರ್ಷ
broth
ಎಲ್ಲ
sample
ಕಡೆ
and
ಜೊತೆ
put it just like a dead stick method, like a fitness detect test. So the cost of this
first time
test
life
is
ಅಲ್ಲಿ
usually
ಜೊತೆ
3,000 to 4,000. There are multiple tests available. And then within 15 minutes you can see that what are all basic common enzymes which are being picked up by this card test. And then you can have a little customization of therapy then and there for the particular
intention
patient
to her.
sample.
ಆಯ್ತು
Similar
ಸರ್
basis, you have a carba ID which is very well standardized even by the ICMR
कुछ
guidelines.
नहीं होता है, इतने से
Now
क्या
this
होगा?
is how that from a direct blood culture. So you have a positive flat culture
बताएंगे बाद
bottle.
में कि
You
हमारे
take that
लिए
1
क्या
ml.
अगर
You put
डरना
it
तो
on
क्या
this the card test, and then you can
कैसे होता
detect the kind of
ये सब कुछ
the
नहीं है।
carbapenem which is present in that particular isolate or a sample.
ठीक है।
And if you see the
अगर
sensitivity and
सुबह से रात तक
specificity
तुमको
from a direct
अलार्म
culture
लगाते हैं,
broth,
फिर पानी
it is
पीना।
quite good. That is more than 95% of the both, which helps in rendering a rapid diagnostics of our resistance mechanism.
Digestive enzyme
Now,
morning,
talking
afternoon,
about a
night,
bloodstream
after
infection,
food.
as we all know that this was a
And
conventional
this is
workflow which we
lactose,
used to
cream
follow.
of in,
You have a culture,
500
you
only
stain it,
night.
you subculture, you identify, and then you put a phenotypic AST.
This is only before
Now for
food,
the
this
rapid
two hours.
test, this part has been laxed
This you
upon
do 3
from
days.
2
If
days
little
to
bit remain,
20
2 more
minutes.
days extra,
So this
go
is
on
how
this
it helps us in
If you will
reaching
complain
the
any
certainly
pain,
fast
antispasmodic,
diagnosis.
one.
Now, MyDTOF is
Otherwise,
being a very popular
antispasmodic
phenotypic test which
for pain,
uses the
stomach
proteomic-based
pain.
analysis
Otherwise,
for
no
the
need of this.
identification of the
Spas?
bacteria.
No, it
But
is little
stepping
different.
higher to it,
Similar
even the
family, but
MyDTOF has
little
also
different.
helped us in determining
And
the
it's not very
carbapenem
sorry,
or
it's
for
our
that matter the
curiosity.
antibiotic
What's
resistance
that?
testing
Sir,
because
I know very
of their
little
kind
about
of a
that, so
linkages
this is my
and
curiosity
how
I
they
asked.
break
This
the
is
particular kind of a
similar,
bond of
but
this
little
carbapenem
less.
and carbapenemases,
Because, methyl
eventually
aspartic
leading to the
mechanic
spectroscopic
acid,
based
which
detection,
will
which
be
is the
useful for
principle
the
of the MyDTOF.
uterus cancer.
And then
Okay.
taking as a
This
standard
one-
line,
This it will
and
be
then the cutoff
overall
these points, we can
This is
detect
dicloman
the
with
percentage
paracetamol.
confirmation that this
So,
particular
nothing
has
to
a
worry. Any
percentage
doubts you can
confirmation
ask.
of the
Dicloman,
carbapenemesis,
yeah.
which is a very faster way of
Not
diagnosing
diclofenac, that
as
is
compared
No, I
to
was
the
just-
original
Thank-
phenotypic
How
AST
are you reading my
methods.
mind?
Now, this is very well known
Because
phenomena.
diclofenac is for
Coverage
pain.
for the
So it's
syndromic
what
testing,
is
we
this
call them
drug
as the
which you
multiplex
consume?
PCRs,
Diclofenac is for
this is
application.
RAs, or
Diclofenac
popularly
usually
known
we
as the
won't suggest
biofire.
for the
We have
small,
different type
small
of
things,
panels
It
available
is very
across
high
the
pain killer.
across the
Energy
places for the
consumption.
different kind of targets
Oh, I
which are
thought
syndromic
diclofenac is only for
diagnosis.
application.
As I said in the beginning,
Application,
culture
injectable,
positivity
and
still have its issues
Injectable
in
I
the
knew,
terms of their
because they've
positivity
given it to me
ratio.
when I
But for the
kidney
syndromic
stone.
testing, this has come very handy with us
All
because
three forms
not
will
only
come.
they detect
Will
the
also
bug,
right now.
but also
देखिए
they have a
अगर-
colony counts
अभी-
in terms of the respiratory
किसको
samples,
कौन-
and also they detect in the terms of
अभी
the
this
AMR
is
gene
one more
detection,
चिंता है।
both for the gram positive and
खाना
for the
नहीं जा
interest
रहा
of
है,
this topic,
खाना
the
बाहर
gram
नहीं आ रहा है।
negative
क्यों
also.
सोच रहा है
But
कि मूर्ति
there is a
है?
caveat that if you have a
ठीक है।
multivectorial
ओ
detection
अरे
from 3
मेरा
to
ये
4
हो रहा है,
bacteria,
अरे
especially
ऐसा हो
in a
गया।
sample such as
कुछ नहीं है।
respiratory
चिंता,
sample or a
कन्नड़ा में
GI
बोलते
based
हैं
sample,
चिंता और चिता
then
में
you
ना
have to
एक
have a proper
शून्य का
correlation
अंतर
because
है।
बस
then it
इतना
just
है।
gives rise to the multiple
क्यों
detection
सोचना
of
है?
the
नहीं
resistance
सोचना है।
genes.
अभी टेंशन
But
हो गया।
mind it, because this is a genotypic based testing, this can just detect
कुछ
upon
नहीं, बहुत
that
लोग
whether
हैं
that
इधर
particular
नेपाल
gene
का।
is present or not present. The expression of particular gene is still defined by the phenotypic testing.
देखो तुम
Now,
टेंशन लेगा
YTED2,
तो
we
काम
are all
नहीं कर
using it
पाएगा।
outright in center,
काम करने
and
के
even
लिए आएगा
that
तो बच्चों को
also
ज़्यादा ध्यान नहीं
identifies
देगा।
our
सिर्फ
genetic
उनके बारे
testing
में
and the
सोचो
targeted
कि वो
genes
कैसा है
which
कैसा
are
नहीं
being
है।
meant for the
लेकिन पूरा
antibiotic
दिन उनके
resistance
बारे में
as
सोच के
explained in the
अपने
previous
आप को
talk.
बीमार मत करो।
Now, just a little bit about the
तुम ऐसा करेगा तो
carbapenemesis
नहीं
phenotypic
मारोगे।
detection. I'm not going to go into details because they are still very, very critically lab methods. So this is a modified Hodge test where what they put is the drug of the carbapenem.
कुछ नहीं,
There is a
वजन
culture of
कम
a
बड़े लोगों में कुछ
quality
नहीं
control
होता है।
which is
बच्चों
the
के
E.
लिए
coli,
वो impact
and then you
वजन
have a
है
test
जाने के लिए।
plate, and this kind of
ठीक है।
shape when it's there, it's like a Hodge
अगर मैं 4 किलो मैं
that
लूज
is
किया
being
तो
divided by
मुझे
the
घबराना चाहिए।
carbapenemase production.
ठीक है।
When we talk
तुमको
about
घबराना नहीं
the
चाहिए। ऐसे
more
सोचो कि जो
you know
गया गया।
scientific and a more little
ठीक है।
fancy principles,
क्या हो गया?
this
Oh
is
my
still a
God,
very
मैं
good
जो-
gold standard test. But
टेंशन
when we
मत
talk
लो।
about
ये
the modern
चिट्टा से होता है,
testings,
पानी
still
की
for
वजह
the
से
phenotypic, in most of the labs, microbiological standard
ठीक है।
labs,
Not consuming
they either
proper
use
water. It's consuming
the
very less.
modified carbapenemase inhibition
Bus,
testing,
always
either by using the imipenem
burning
EDTA
hot
or a
so
meropenem
burning
EDTA, where
ठीक
they
है,
see
बैठिए।
how,
नहीं।
because EDTA is for the metallo-beta
कुछ पूछना
lactamases
इनसे मैं बाहर
production,
हूँ।
and they can see that a drug
कुछ-
alone,
कुछ-
a carbapenem
कुछ-
alone versus
ठीक है,
the drug with
मेरे
the
पापा ना
EDTA,
मैं बोला ना
if there is a
45 साल
change
से
of a threefold
दवाई बेच रहा
dilutions of your
मेरा फर्स्ट
concentrations,
मैं
that
हमसे
clearly
पहले दवाई नहीं
indicates
लेता
that you have a carbapenemase
तो
production,
जो भी बात करते हैं
specifically
डॉक्टर से
talking
बात
about a group B carbapenemases, which
वो
is the
बताएंगे
MB.
अगर
And this is what I was
Because I keep
mentioning,
telling her
that
घर पे
alone versus the alone drug versus the imipenem plus the EDTA molecule. How does it differentiate and getting the MIC score lower? So this is what I was mentioning about. And then comes the molecular testing in a most fast forward form, expert carba-R, which is a little qualitative. It's a real-time PCR we have all heard, and we all do the gene expert like for the tuberculosis. So this is for the carbapenem resistance testing, and that simultaneously detects and differentiates of the common five carbapenemases enzymes, which is KPC, NDM, VIM, OXA48, and IM within less than 1 hour. And this is approved from all the culture plates and the colonies. So there has been a huge data and publication about the expert carba-R, which says that there has been this big data which shows close to 1800 isolates, and the sensitivity as well as specificity of this carba-R in isolating these and in agreement with the culture-based techniques was close to 95 to 98%, whereas the specificity is close to even 100%. So these are the tabulated version of the rapid molecular testings plus the phenotypic testings which are required. They can be mostly done from the bacterial isolate. The plasma mining is directly do from the positive culture techniques. But as I mentioned, they detect the majority of the enzymatic mechanism, which is the carbapenemases production. Advantages, we all know the TAT is very, very important. Those influences and helps us in a lot of stewardship perspectives. Disadvantages, as we all know, that it requires still the culture growth. Multiple times, if you have more than one bacteria, sometimes it just gives the picture. Now coming to the next aspect of it, as I have mentioned that you have got the bug, you have got the carbapenem resistance. Nowadays, with the more advent of newer beta-lactam and beta-lactamase inhibitors, and commonly which I am talking about is ceftazidime avibactam plus astronam or astronam avibactam, the things doesn't end here. Your carbapenem resistance is defined. Now you have to think about putting up this antibiotic into the perspective. You have to also think about their synergy testing or astronam avibactam based MIC ETES based testing which is available. And that is very important because we have seen the discordance also. Many a times you have a OXA48 being positive, but you still have the astronam avibactam being sensitive. And the vice versa is also true. So synergy testing is still very, very important if we are using this kind of a molecule. So the broth and a disc-based elution system or a drug elution system is something using the tubes as an antimicrobial agent source is the most common technique which we are following in order to continue the usage of this product in the isolates or in the practice also. So the similar thing which we have applied now culminating the entire thing together, the patient was upgraded to ceftazidime avibactam and astronam because at that time Emblavir was not into the picture. Klebsiella pneumoniae was grown. It was resistant to carbapenem. You did the carba testing, but you simultaneously formed the synergy testing. And when the synergy was sensitive, we already upgraded it because of the empiricity. But you can continue doing that if your bug is showing the synergy sensitive. Like this is the thing. Now, this also has been incorporated in your iconic guidelines, which has been the country-built guidelines, that the validated molecular testing of the resistance mechanisms in conjunction with the phenotypic testing should be done, specifically when you have a CRE and a critically ill patient, which was a 1B recommendation. Validated lateral flow test and carba-NP and phenol-based tests are more commonly in that. It's for the rapid TAT and excellent agreement with the molecular testing. Synergy testing should be routinely performed for all the carbapenem resistance enterobacterial specifically in a critically ill patient. Still your astronam avibactam are not available, but nowadays we also have a good supply for astronam avibactam based e-test RR centers. And testing for cholesterol susceptibility, which is also very important, is using the broth microdilution. That is most important because Vitek alone will not do a justice for the cholesterol resistance testing. On the same principle, when we also did the testing, and I tell you one caveat also, most of the centers still use the disc-based synergy testing, and that was the scenario when we used to do till last 6 months, and we found out that our synergy is getting lower and lower, and especially in E. coli also. And then when we switched to a drug-based dilution testing system, which is still a gold standard for synergy, the synergies, actually the results were much better, but still in the current resistant era, we are only getting 70% of the synergy being sensitive. Now moving on to the next step, this is a patient who is 53, diabetic, uncontrolled, and I'll just skip the major points and fully coming to that this patient had a ventriculitis and a meningoencephalitis, and the patient grew the Pseudomonas aeruginosa. The glucose was 10, proteins were very high, cell count was 150, neutrophilic predominant, classical case of the bacterial ventriculitis with meningoencephalitis. So this patient has a Pseudomonas aeruginosa, and you can see that meropenem being sensitive and imipenem being resistant, and the other is the cipipine being sensitive, ciproflox, amikacin sensitive, and cholesterol intermediate. This was the old report for that patient. And what are the mechanisms? Though this has been already discussed, but just from the interpretative category, I would highlight that there can be many scenarios, specifically in Pseudomonas aeruginosa, where in your antibiotic sheet you see, oh, meropenem sensitive, so you automatically think or IMI sensitive that they are the similar class, and you can have a cross reactivation, and then you can use one or two invariably. One very important thing, though they all sound same, ferropenem is not a carbapenem, ertapenems are still not at all used for the acinetobacters in Pseudomonas, and in Pseudomonas, there can be a scenario where meropenems can be sensitive but IMI resistant, and that is not only because of their enzymes but also because of their protein efflux pumps or the OPR mechanisms, as I mentioned in the previous slide. So that also highlights and that also helps us in narrowing down the antibiotic therapy based on their mechanism of resistance. So if you have a positive, and already mentioned by Dr. Parikshit that just carbapenemases can still go with this, whereas in the MBLs, you have to resort to the second line options. And here even the Astronam-avibactam is not that a great drug of choice for Pseudomonas. So cefepime zidibactam, which is coming very shortly, cefiderocol, high dose amikacins in few cases, despite being on a kidney injury, and plus minus polymyxin based therapy can be utilized in this. So I'll just highlight the three things again from the sensitivity profile just to make you more clear understanding. So this is what I was talking about. This is one interpretative report where you have ceftazidime sensitive, mero-resistant and IMI sensitive. The mechanisms are usually efflux pumps. So this is not a wrong report. First you rule out the technical glitch, but there can be a scenario where it fits, and this is the mechanism which is interplay. The second perspective is you have a amica sensitive and all are resistant, which is a usual phenomena. You have a combination either of enzymes plus minus of the efflux, because you know the porin pumps and the OPRD efflux mechanisms can be highlighted to two different mechanisms. One of course is the genetic sequencing based, and second is you have to have a time kill assays based approach, which is sounding very fancy and very researchful, but for a routine bedside diagnosis, it's still very cumbersome to utilize on that. But as I mentioned, that these kind of patterns of sensitivity makes you an idea in a lab or in a bedside that this particular bug can be been operated not only on enzymes but also on the efflux. And then the sensitivity pattern 3, you have ceftriaxone sensitive, ceftazidime sensitive, but the carbapenems are resistant. And then we used to think, okay, this might be a wrong report. But no, there can be a porin loss, again seen lot of times in Enterobacter, Serratia, and even in Pseudomonas, that this can be also a mechanism of action also. Now, this is just to give a final glitch that you have a carbapenemase detection, you have a rapid phenotypic lateral flow assays and or all molecular testing backed up. You have enterobacterials detected or a non-fermenters detected. Then for the non-fermenters, you know you have to have either, if you have an acinetose albactam plus based therapy with the polymyxin piece, or if you have a Pseudomonas polymyxin based combination therapy. But if you have an enterobacterials detected, reveals KP or an E. coli, or you have known carbapenemase not detected or rapid testing is not available, then for the KP you have SARS or with the MBL, de-escalation for the monotherapy. If you have an MBL, test for the synergy, or for Astronam-avibactam, go with their MIC being detected. For the CR and E. coli, you have to see along with the PBP3 inserts, and most of the time how we can reflect it is see the Astronam-avibactam synergies or your synergy drug elution. You will see that if that is also resistant, the person the E. coli is having that PBP3 mutations, and then either you have to continue based on your synergy testing, or you can switch to
rest.
plasmicin or ibuprofen plus minus 40.
ಎರಡು ದಿವಸ
If carbapenem is not detected, until your phenotypic susceptibility is not there, you can de-escalate. Rapid testing not available. Still a little caveat because, of course, in the today's era, it is quite a common and handy procedure. But then, wait for your phenotypic testing reports to come after 48 hours, and then you can take a call. Now, just to conclude, interpretation of breakpoints must be according to the latest standards, and that has to be updated every time. Selective reporting is essential, and most of the labs now do cascade-based reporting system, because you cannot show everything on the plate, because it's not just a lottery system, pick and choose. You have to have a cascade-based reporting system like a tier 1, tier 2 and tier 3 as a good perspective from an antibiotic stewardship. Guidance of the therapy based on not only the interpretative breakpoints but also the resistance mechanism, both by the phenotypic, molecular or a rapid card-based test, helps in PK/PD correlation, also the choices, also sometimes the dosages as well, and also the site-specific targeted therapy. MIC determination, as I mentioned, is always there. Disc diffusion, specifically when we talk about synergy testing or something, is still not very good thought process. And of course, quality control checks must be periodically performed when we are talking about this, because a lot of things are getting relied on this. So thank you so much for your patient listening and open to questions. Thank you.
Thank you very much, Dr. Neha Rastogi, for this wonderful session. It's a very complex topic with great clarity, and where you describe the clinical interpretation very beautifully. Now I'm going to start with a few questions. I think we'll take questions for Dr. Parikshit first, just so that we can understand a little bit of his topic more. I mean, some of these questions may sound a little repetitive, because you probably have already covered it in your presentation. But just for emphasis and for more clear understanding for the listeners, I'd like for you to I'll ask a couple of questions and you can explain accordingly. The first question we'd like to go to is, which carbapenemase class do you think is currently most prevalent in Indian ICUs? The NDM, the OXA48, or the KPC? I mean, just for a little bit of an overview on this, please. Dr. Parikshit.
Yeah, so KPCs, like I said, is very rare. NDM and OXA48 both are really important problems. If you look at our E. coli, they produce a lot of NDMs. In our settings, almost 70% of our E. coli produce NDMs. Some of them may even be co-producing OXA48s. When it comes to Klebsiella, in our hospital, it's about 50-50 NDM versus OXA48 producers of when it comes to the carbapenem resistant organism. So NDM and OXA48 both are very, very important. KPC not so much in terms of the prevalence.
Thank you for that. I think a couple of next questions were sort of the similar questions. Apart from carbapenomases, what role does foreign loss play in resistance here? I think we already covered this, but just a couple of lines to re-emphasize what you already said, please.
Right. So, especially in organisms like Pseudomonas, there is increasing data in Klebsiella as well now. But in organisms like Pseudomonas, if a carbapenem is resistant, it may not always mean production of carbapenemesis. So, like I said, CR and CP are different terminologies. CR is carbapenem resistant, whereas CP is carbapenemase producing. So, CR is not equal to CP. So, their foreign loss does play a role. Of course, it doesn't raise the MICs, frankly, as much as let's say an NDM would, but they do play a role.
Thank you for that. Now, there is how do we distinguish carbapenemase producing CRE from the non? I think that's exactly what you're talking about. Can you just emphasize it a little bit more from non-carbapenemase negative? Yeah.
Correct, and I think question number 4 is also similar. Does efflux overexpression add meaningfully? So, all the non-enzymatic mechanisms do add meaningfully to it, to the MICs. If you look at efflux-mediated resistance, again, it will depend on what type of efflux you're talking about. So, for example, if you look at this Pseudomonas, then if you look at this MEX-EF or OPRN type of efflux, then you will have, both imipenem and meropenem being affected, but maybe not frankly resistant. So it will be, sort of a raised MIC, but not frankly resistant. The other types of efflux upregulation, which means the MEX AB or MEX CD or MEX XY, they affect meropenem far more than they affect imipenem. So when it comes to efflux, again, it largely depends on what you're talking about. In general, efflux raises MICs but may not produce frank resistance. And similarly, if you look at the mutated porin channel, so loss of OPRD, you will see that imipenem is affected more than meropenem. So there are subtle differences there. So it really depends on the type of mechanism that you're talking about. But like I said, in general, they do contribute. You don't see MICs as high as, let's say, when you have an NDM producer there, but they do contribute to the MICs.
Thank you again. We go to the next question. Of course, we know that now that the NDM and the OXA48 are most relevant for us. Now, is there a difference in mortality between the NDM producing and the OXA48 producing infections?
So, before that, we need to realize that mortality and virulence are different terminologies. So, you can very well have a pan-susceptible isolate, which is very, very virulent. We classically see that in the hypervirulent Klebsiella as well. So, an organism need not always be carbapenem resistant for it to have mortality. Again, mortality is a very complex process. So if you look at attributable mortality, then it really depends again on the host type, the site of infection, the inoculum, and all these other things. How quickly have we done source control? So the enzymatic mechanism is just one piece of the puzzle.
Yeah, very correct. Thank you very much for that. Now we want to talk a little bit about the hospital settings and how this resistance gene how resistance is worsening. For instance, how easily do these resistance genes transfer between the enterobacterial species in hospital settings? Like between patients that you're seeing different carbapenemases or different mechanisms of resistance already, how is the commonality being progressively increased?
Well, unfortunately, yes, it is common. Again, you have plasmids which can do that. So horizontal transfer of resistance is pretty common, unfortunately, in the hospitals. Most of the hospitals in India don't really have the means of isolating, resistant gram-negative infection patients for the sheer burden of it. I mean, isolating TB and Clostridium difficile is hard enough. So if we start isolating, CR patients, it really becomes very, very difficult. Yes, some of these patients can be. So for example, let's say transplant patients or the hematology ward, those are slightly different settings. But I think in general, it is practically not easy at all to isolate these kind of patients in India. Again, nursing and infection control, we have a lot of challenges when it comes to the staffing and the manpower. So these, unfortunately, because of this, we do see transfers. Again, I mean, and again, these bacteria also have plasmid-mediated horizontal transfer. So everything combined, there's a reason why we see such high resistance rates in our ICU.
Thank you. Just a quick word on emergence of colistin co-resistance with carbapenemase or carba-resistant isolates.
So in general, the short answer is that it is rare. Again, it depends on the organism that you're talking about. Klebsiella, you could see slightly higher MICs than, again, now we don't use the word colistin susceptible. So it's either intermediate or resistant, but Klebsiella, you could definitely see higher MICs. E. coli, for the most part, has remained manageable. So has Pseudomonas and Acinetobacter. So you don't see very high numbers there. You would see the odd isolate which has MICs of more than 2 or more than 4, but in general, it is not very common. Except for CR, Klebsiella, sometimes it can be a problem. And also one thing, when it comes to colistin resistance, a lot of these panels detect MCR-mediated resistance. Again, that's not the commonest way by which colistin becomes resistant in the Indian setting. So right now, we don't have a very good genotypic way of identifying colistin resistance. So it has to be done manually and has to be done by the right kind of methods.
Thank you very much. The next question, I think, will also overlap to Dr. Neha's talk, where I want to get your view on what do you think is the current gold standard way for carbapenemase or carba-resistant detection in a resource-limited lab? I mean, when we have all of these techniques, that is, of course, possible. But what would you advise for people who are working in places which is resource-limited?
I think most of the labs do have, of course, the phenotypic sensitivity is, of course, mandatory. That is nothing out of question. And then the second two things which we can think about is, one, most even in the resource limited settings, at least the modified carbapenemase inhibition method, the MSIM which I have mentioned, and the EDTA based methods, which are just the discs only and the E-strips only, that is something which comes very, very handy, and that can be done from a same plate where you are doing a routine sensitivity testing. So the combination of the two, the MSIM and the eSIM, which is with the EDTA, can be a routinely handy diagnosis, because you can at least have a differentiation. Not only the carbapenemase is being detected, but you can have a differentiation between an MBL for the EDTA ones, eSIM, and the serine carbapenemases for the other three classes which we have talked about. A little fair better, I think the Vitek comes next, or at par with the MSIM and the eSIM. If you don't have a perspective of a rapid testing, or forget about the molecular. Yeah.
I'm going to go down a few questions and we'll come back up again. What's the turnaround time difference? Because that will emphasize, for everyone that's listening, the between phenotypic and molecular methods. That is kind of going to be key for a lot of people, especially when you're talking about resource limited versus resource rich setups.
Right. So two things which we need to know. So molecular, so first I'll talk about the syndromic when we talk about the multiplex PCRs, because that is directly from the sample. You don't need a culture-based positive growth or a pure growth. So that comes at the cost of 1 to 4 hours, which is very, very time-dependent decision making when we are talking about a patient, talking about as a very precious patient. Okay. Then comes the second thing is the molecular-based testing, that you have a blood culture broth or you have a positive growth, and then you are just applying those genetic testing methods. Again, the time limited testing is 48 minutes to barely 120 minutes for your processing time limits. Then comes the multi-TOF, which again, after the growth or after a blood culture flagged bottle positive, take 2 hours for the identification and 1 additional hour for the carbapenemase hydrolysis. That comes to the 3 hours. Then you come as a rapid testing. The problems with the rapid test or the rapid card based testing is, again, you require a group. So first you have to have a culture positivity for that, and when it comes in 18 to 24 hours, then the positive growth will require only 20 to 30 minutes, including the processing time. And last, when I was mentioning about the MSIM or an eSIM, that takes almost 24 hours, because you have to again plate it, again grow it. So that time taking is another 1 day extra, apart from your culture being grained on the growth. So I think this is how we grade the timings.
Thank you very much. This is a question for, I think, the lab. At what MIC breakpoint should we suspect carbapenemase production and trigger confirmatory testing, like from the lab perspective?
So I think that, first of all, there is no single answer to it usually. So usually when we talk about, you have a sensitivity method. So when we think about the non-susceptible is something which is very easily readable, that this is something which is non-susceptible. Then comes the category of your intermediate or a resistant. You have 3 carbapenems always in your block: acceptance, pseudomonas, and acinetto. So for those 3, if you have all 3 in the resistant category, suppose you have majority in the meropenem, you have an intermediate category, you have an idea that you have to go for a higher dosing. Then the third important thing is, as I mentioned initially, the non-susceptible limits. And then the last thing is that you have the entire all the drugs being resistant in the carbapenem group, and only sensitive, which is most of the common time scenario these days, to intermediate to either cholesterol and NET. And then followed, that is actually urging you to the trigger for the confirmatory testing, that there is something wrong with this particular group. You already have graded it to the ESBL, and then you have come to all the 3 carbapenems simultaneously being tested as non-susceptible, or in some areas where you have one resistant, the other sensitive. Think about the methodology other than, or a mechanism other than the enzymatic degradation. So this is how you can take a stepwise approach.
Thank you for that. So again, going back to the smaller hospital labs where we don't have the extensive testing capabilities, how do they approach carbapenemase screening? We talked about the initial phenotypic screening and then the multi-step approach from there. Now, once a carbapenemase is identified, immediately what should they do? Should they change their antibiotic therapy right away and then try to do some further testing? What would you advise? Like what would you advise a smaller hospital which has limited advanced testing?
So I would like to first offset is, this is again a thing that this platform is also necessary to mention, that we do have a very good rapid testing available nowadays. So first of all, even for the smaller lab, when we talk about, we do have a handy things available, at least for a little screening perspective of a carbapenemasis in order to avoid the time settings. Now talking about a totally condition where you only have a phenotypic DST available, but as I mentioned, the carbapenemase inactivation methods are something which are very well ICMR approved even for the field testing labs, because you just need the same agar plate which we are growing a growth, and you need a EDTA based discs also. Now talking about, as I mentioned in the previous question also, that when you have a sensitivity in between you and you can see either a non-susceptibility or a resistant profile in the carbapenem arm, apart from the bug being already in the ESBL, and you have landed up in a carbapenem group where you have the commonly in the congeners word of the imipenem, meropenem and ertapenem in the most of the scenarios. If you have a disc diffusion, it is either a sensitive, intermediate or a resistant. So if you find the resistant, or if you have an intermediate, think about and start thinking your clock towards that there's something wrong with the carbapenemases, there's something with the carbapenemases production. Then you think about the other drugs again in the scenario, because you have an entire antibiotic susceptibility picture, and there you can think and elucidate certain mechanisms which I had shown in the last two cases as well. So this is a little, I would say, a basic proactive approach in order to get that. The only limited time will be, of course, you need a culture positivity, and of course the time taking for the growth.
Fair point. Dr. Chavla, you want to say something?
No, I just want to say, a lot of people are there, close to 1,000 people, more than that. You see, I just want to say that don't get perturbed, because you see, we have the very eminent ID people speaking on this. It just gives you an idea that how complicated it has become to treat the resistant infections. And the more knowledge you have, the more appropriate you are. Because just getting a rapid culture report or a report, you have to see patient, you have to see why it is not working there. It is not if you get a biofire, it is not the only mechanism that there may be another mechanism. That's why you are using CAS-AV, you have OXA48, still patient is not good, because there is another mechanism. Or is a pseudomonas which has a multiple mechanism. So all these things you need to know. So that's the reason, we have kept so many 4 modules on this. So there's a lot of repetition. And by the end of 4th module, you will be listening everything again, and you will know all this. And they have taken state-of-the-art lecture, because I learned a lot in these lectures, because many of the things I was not aware of. And many of these things you have already heard, the methods and everything we had talked at the beginning, and maybe in recap she will again talk about this. There are a lot of other questions, but we are really short of time. And the one advice, Dr. Parikshit, if you have to give to people, that how to deal with carbapenemase resistance. Although it is a very difficult question, but what is your take on this? And then I'll ask Dr. Neha.
One advice, sir. One advice is a little tricky.
I mean, you can give many advice, no problem.
I think talk to your microbiologist and ID team.
That is I think the crux. And because when you are dealing with a complex problem, if you have ID people, person in your hospital, that's the best way. And if you don't have, you can talk to the microbiologist, because he will clarify a lot of things, and it will increase your understanding of the mechanism. If you keep on talking 5-10 times, the 11th time you may not require the microbiologist, because you already have the knowledge about this. Because in this fast changing time, we have very few drugs. We need to preserve that. Fortunately, as Dr. Parikshit said, the colistin is not developing that much of a resistance as of now, but it's a matter of time when the CAS-AV or Acetinomycin, they're also going to fail. So we need to preserve them, use them appropriately. If there is a drug which is a simple drug and is sensitive, if it's a carbapenem is sensitive, don't use because your patient is sick and you use CAS-AV. Because we do all the time. Patient comes on CAS-AV, we put him on a very simple drug. Many a time we just put on a ceftriaxone and doxy is a community quite good. So that was the purpose of this program, that you should preserve drugs and use appropriately. Do not when you try to use a high-end drug, does not mean your patient will get better, because if there are simple options, they're better. Similarly, we had talked about staph. If it is MSSA, vancomycin is not better. It is the fluoxetine, flucloxacin, cefazolin, they are better drugs. So this is the purpose, that always remember that you need to be appropriate, and that's how the IT and the microbiologist will help you. And try to learn to believe in your lab, believe in yourself, and believe in your setup, that what you are, because then only we can prevent. Otherwise, it's a matter of time. Every patient will require ID, and will have to have 4 or 5 drugs. So I don't want to have that kind of situation. So that is the purpose of this. And what do you want to say, Dr. Neha? Anything?
I think most of the things have already been discussed. Just to highlight and reinforce, sir, that antibiotic stewardship, when we talk a lot in these days, the major goal still lies in the diagnostic stewardship as well, because all of us have an escalation policy being quite rational, because you need to save. But the point is that if you are highlighting and if you are escalating a drug, and as you have mentioned, that every disease does not require a very higher antibiotic. And that's why majority of the times when we talk about, because these days lot of tests are available. So the one basic advice which I say is that think about it, read, see the patient. Clinical correlation is still the utmost important, because many a times these fancy tests will have just detection of XYZ genes, whereas your patient is getting better. Talk to the microbiologist, as Dr. Parikshit has mentioned. So, I mean, the communication still is a key till date and in this era as well. And then, if you have a particular sensitivity being reported, start de-escalating also. So, not only about the diagnostic stewardship matters that you have sent a good test and you got a good result, but treat that patient also as a part of it when you have a clinical response. So, start de-escalating also. So, that is something which I want to say. Yeah.
I'll tell you, Dr. Parikshit, since the time we've been hearing this, our practice has changed tremendously, because hearing the IDs talking again and again, we have tried and it is working out. And I'm sure many of you who are watching this, if you have watched the last 11 modules, and we are going into too much detail, and we are making you ID. If you go into this, you will be better person, and then you can discuss with your ID and microbiologist in a much better way, and you can help the patients. So with this, I would like to thank Dr. Hemlata Arora for moderating this session, and Dr. Parikshit, who conducts ISCCM Critical Care Infectious Disease e-course that's going on. He's written a book also on the critical care infectious diseases. Dr. Neha took a wonderful lecture on the laboratory methods, and we're going to repeat. As you know, we are repeating in every, and there are a lot of things you will find the different flavor from different teachers. So with this, I would also like to thank Dr. Akansha, who has a very tough job. Every week she's taking lecture, and she has to simplify, because it is not that easy to simplify these kind of lectures. So, but I think we will try to give you more messages in the next week. And with that, I would also like to thank Exidon for conducting without any hitch, and also Design Biosciences for supporting us. Have a good night. See you next time with difficult to treat gram-negatives and newer drugs by Dr. Tony and Dr. Sayan. These are the 2 talks next time, and we'll begin with the recap of this at 7:30 after just exactly